in Michigan. Dr. Simoncini, I'll turn it over to you to get us started.
Yeah, so that just aged me, the introduction. Um, College of Osteopathic Medicine of the Pacific is now called Western University of Health Sciences. My residency, it says Botsford General Hospital. That's really Michigan State. Okay, I spent most of my time in Detroit, which was actually fantastic. Um, Nonetheless, Botsford, Michigan State, that's in Lansing, Michigan. My fellowship's through the College of Osteopathic Surgeons. I've been a fellow of the College of Surgeons for, I want to say 27 years now. So we're going to talk about one of my absolute favorite topics tonight. It's male stress incontinence. And the reason that is, I want to go over what it is in just a second and show you how many people it affects worldwide. But more importantly, if you can correct this problem, your quality of life is night and day better. It's an absolute game changer. Stress incontinence is basically the leakage of urine with activity or pressure. Anything that puts pressure on the bladder that's stronger than or that's more so than the urinary sphincter can hold, you're going to leak, like with coughing, laughing, sneezing, running, heavy lifting. Now, that happens on a continuum, though. Some patients, it's, way over here, meaning they might swing a golf club and leak a drop, to patients over here where they're leaking and using, I mean, just moving around, they're leaking and they're using multiple diapers per day. And those patients, we can really make a huge difference in their quality of life. Again, it's a game changer. But there's 13 million men worldwide suffer from stress urinary incontinence. So pretty common. In the United States, annually 17,000 men develop stress urinary incontinence every year. And that's probably very accurate. Next slide. So let me go over how the urinary process works with you. So the bladder I can't point, but the bladder is up on top where it says bladder, basically. And the bladder's a muscle, a hollow muscle that's filled with urine. Okay, and it has two functions. One is it's supposed to store urine at a very low pressure, and then it contracts when you want to urinate. The prostate is just below the bladder, and it's the back portion of the urethra. They're showing the sphincter muscle as well below the prostate. And they generally, when it's drawn like this in a really nice drawing, it shows it in a strip. Well, it's not just a strip, it's a hammock sort of structure that goes up around the base of not the base, I'm sorry, the apex of the prostate as well. So it's not just like a straight muscle, it's almost more like a suspension bridge underneath there. And then the urine comes out the urethra. So don't ask me why I found this really cool when I was a third-year medical student, but the bladder, when it contracts, it squeezes to push the urine out, and the sphincter muscle has to relax. When you're trying to hold urine in, the sphincter muscle contracts and the bladder has to relax. So they work opposite each other, and there's medicines that affect both. And that I was doing a rotation with my uncle that was a urologist. That day, I just happened to be with his partner, and I remember him explaining that to me. And we saw so many, patients that were on the wrong medication for the problem that they had. So that was part of what got me interested in stress incontinence in men and women, but very common in men, unfortunately. Next slide. So there's common causes and comorbidities associated with stress incontinence. And the most common is after removal of the prostate for prostate cancer, where we're removing the entire prostate gland. So in that diagram there, the part that's like a light blue or powder blue, that's what we remove during a radical prostatectomy. Now, why is that important? Well, we showed the sphincter muscle, which is a voluntary sphincter, meaning you can contract it on nation. When we remove the prostate, you lose that involuntary sphincter. So you really have to strengthen the external sphincter, which is below the prostate. So radical prostatectomy, my opinion, is probably by far the most common cause, but it can be caused by radiation therapy. When it's a combination of surgery and radiation therapy, it seems like it makes the problem worse. Okay. Because both of those can affect the therapies and they affect the external sphincter and the muscle functionality of the sphincter and the bladder. So other causes, one is benign prostatic hyperplasia surgery, which would be like a TURP, or they'll call it a roto-rooter roller hollowing out the prostate. I've never really had a patient have stress incontinence from that, but it can happen. Spinal cord injuries like neurologic conditions can certainly cause stress incontinence. Pelvic surgery, um, another one that causes it is like when we're removing the rectum and the colon um, for colorectal cancer. That's another big one that causes these types of problems. And many urethral surgeries can cause it too. But I think the one I see the most anyway is after a radical prostatectomy. Next slide. So why is this really important? Well, stress incontinence, again, that's leakage when you cough, laugh, sneeze, and it's a continuum. It might just be a drop when you're doing heavy activity, but then again, it might be constant all the time where you're using multiple pads per day and you're basically miserable. Okay, so can it really affect your quality of life? Um, so they say men with urinary incontinence have higher chances of depression. I think that's absolutely true. And the worse the incontinence is, people were using 9, 10 diapers a day. They're usually not real happy. Call it depression, call it what you want. They're usually not real happy. The more severe cases of depression. The good news is we can change that for them. Next slide. Male stress incontinence and prostate cancer. So the link between stress incontinence and prostate cancer, there's 90,000 radical prostatectomies performed each year in the United States. Now, most of those in 2025 are performed robotically. And, that's a little bit better, actually a lot better surgery than what we used to do in the 90s, which was an open prostatectomy where we make a big incision. The what do I want to say? How precise a robotic assisted prostatectomy is, how little blood loss we get, um, significantly better. The problem being you still get the same problems. 9 to 16% of men post prostatectomy, no matter how you do it, are still having some leakage a year after treatment. Albeit it might be minimal, that's about the numbers. 9 to 16% still may have it after about a year. Next slide. You can switch it, Jamie. So stress incontinence and prostatectomy, this is just basically showing the anatomy. So the slide on the left is normal anatomy. You see the bladder on top. The prostate is circled in blue, and the urethra is below that. When we remove the prostate, we're basically removing what's called the base of the prostate, which is the part closest to the bladder, and the apex of the prostate, which is the closest to the urethra. So we can reconstruct that robotically with suturing that is actually very well done with a robot. And we reattach the urethra surgically to the bladder. I say we reconstruct it. It's a lot better than we just reattach it. But that's basically what's going on. But what happens, which I'm sure we're going to get into in a second, that's involuntary sphincter that helps you with continence around the bladder is gone. The lower sphincter, that's a voluntary sphincter, that, it comes up around the apex of the prostate. We have to tease that off, dissect that off. And then once it's done, you have to relearn how to use those muscles again. It almost reminds me of like a shoulder. A shoulder has so many different muscles that are have to work in coordination together. And it's the same with the sphincter muscle to control your urination. Next slide. So what are the treatment options for stress urinary incontinence? So some are just behavioral changes, and a lot of my patients seem to pick up on these on their own. Okay, so one is if you just drink less fluid, you won't leak as much. Now, is that necessarily good for your kidneys? Not really. But if you drink a little bit less, you're going to leak a little bit less. The next is called planned restroom break, or they're calling it planned restroom breaks. What that means is called time voiding. That means like maybe every couple hours you go and urinate, whether you have to or not. That keeps your bladder more empty, which leads to basically leaking less urine, if that makes sense. We have some minimally invasive interventions. So the one thing, if you look at the second highlight down there or second bullet point is called Kegel exercises. That's the beginning of the mainstay of therapy. Kegel exercises help you strengthen the sphincter muscle. And what that is basically if you're trying to cut off your urine. I usually have patients do it 10 repetitions, 10 times a day. Sometimes sending patients for physical, pelvic floor physical therapy. We have a group that just does that. They specialize in incontinence physical therapy. They're very good. That's a little more extensive than just the Kegel exercises. Sometimes they use biofeedback and they actually put a nerve stimulator on the muscles that you need to contract to control your urination. Now, why is that important? Um, I hate to say this, but I can tell a woman to do a Kegel exercise and they know exactly what I mean. I can tell a man to do a Kegel exercise and they contract every muscle in their body except for the right one. So sometimes biofeedback is very helpful. It teaches the man which muscles need to contract so they know which ones to exercise to regain control of their urination. So what about coping mechanisms? Well, you're going to have to, people have to wear pads. If it's really bad, they have to wear diapers. Catheters we try to stay away from, but you can use like a condom catheter or a catheter to collect the urine. Uh, Certainly not ideal. Penile clamps, there's one, they basically go around the urethra. There's one called a Cunningham clamp that's been around for 35 years. They work, but they're relatively uncomfortable. But can they work to a degree? The problem is it can cause some skin breakdown below the clamp if you use it too often. But those are some coping mechanisms. So what I'm trying to get at with this, showing these coping mechanisms, do they help? Yes. Is it a lousy quality of life? For the most part, yes. So there's other things we can do to help and correct this and make your life a lot better. Next slide. So one of the treatments is called an advanced male sling, advanced male sling. So what does that do? A sling, there's going to be a picture of it coming up, but it goes around the urethra and pulls up on the urethra. So what does that do? If this is the urethra, it creates a backboard and helps it stay closed. Um, it's for mild to moderate stress incontinence. So remember, I'm saying this occurs on a continuum. It can be really bad or it can be not so bad. The ones that are not so bad, that maybe leak a little bit with activity, they are good candidates for a male sling. It's minimally invasive. Um, you don't have to do anything to it for it to help your continence. So one of the studies showed that it causes, or not causes it, we get about a 77% reduction in pad use, which is nice, but there's one man much wiser than me. He was a pediatric urologist. And I remember we used to have this neurologic clinic and we'd go around and everyone, we tried different medicine and they'd say, oh, he's, 40% better or whatever. And he'd say, none of that really matters. Their quality of life is still lousy. You either want them dry or not. So a sling, this is how I look at it. And this is my personal opinion. Boston Scientific might not 100% agree with me, but when I use a male sling, it's for somebody with very mild incontinence. And why? Because I want to be able to make that patient dry and really improve his quality of life. Okay. So if they leak too much, then it may not tend to work quite as well. But this is a sling. They're showing in this with this mesh here. It's a sling that goes around the urethra and pulls up on the urethra. It creates a backboard behind the urethra and helps it stay closed. You don't have to do anything to make that work. Um, about pretty close to 90% of patients would recommend it to a friend. And I think the key is doing it on the correct patient. If you do it on the correct patient, fantastic procedure. Next slide. So what's the gold standard treatment? Well, the gold standard treatment, it's a little bit more involved. It's called an artificial urinary sphincter. The thing with an artificial urinary sphincter, it's been around as long as I can remember before I was a student. It has been around for about 40 years at least, maybe more. But it's designed to treat stress incontinence in men, usually following prostate cancer surgery. And the nice thing, it can treat anywhere on that continuum of stress incontinence. It can treat the real bad cases and it can treat the mild cases. The whole thing is it improves your quality of life. Like that's a game changer, night and day. Okay. They're all internal. Um, there's a picture. I'm gonna show you what it actually is. But the artificial sphincter goes all the way around the urethra and it holds it closed. And so it stops the flow of urine when you don't want it. When you want to urinate, there's a little pump down in the scrotum that you just squeeze one or one and a half times. You urinate normally and then it resets itself. It's really like a phenomenal design. You do have to have some cognitive ability to use it and some manual dexterity. That being said, it's very easy to use. Next slide. So this is an artificial urinary sphincter, and what they're showing where it says cuff, that's the cuff that goes all the way around the urethra. There's a pump down in your scrotum that's small. You'll never see it through the skin, but you can feel it. And there's a fluid reservoir. So that cuff is holding the urethra closed. When you want to urinate or when your bladder fills up and you have to go, you squeeze the cuff, or you squeeze the pump, I'm sorry. Squeeze the pump and the fluid goes from the cuff into that reservoir. It's a pressure regulating balloon. And you're able to urinate normally. And then somewhere between 30 seconds and a couple minutes, it resets itself. Just a beautiful design. Um, uh, Again, this to me, I mean, the reason I wanted to do this lecture, this is just a game changer. You can improve somebody's quality of life from terrible to fantastic with one, it's reasonably minimally invasive procedure. New line or new slide. So this is a schematic of how it works, okay? Which I haven't seen the schematic, so let's see how it looks on the schematic. So there they're showing the pump with the cuff around the urethra. When you squeeze the pump, the fluid goes up into the reservoir. You urinate normally, and then it refills on its own. Um, Very easy to use. Very easy to use. These are the kind of procedures, say, like I'll do these and then I'll activate it for a patient and I'll say, well, call me and let me know how you're doing. And I won't hear from them for 10 years until it wears out and they want a new one. Um, but they're excellent. So what to expect? Well, it's an outpatient procedure. That's really nice. The incisions, there's different ways to do this. There's really two ways to do this. Most of the doctors out there are going to make two small incisions, one behind the scrotum and one up in the groin area. So why is that? They put the one behind the scrotum is to put the cuff in. One is up in the groin area to put the reservoir in. Um, I generally tend to do it between the penis and scrotum. And the reason I do that, I can do it all through that one incision. Um, if you know how to get down to the right part of the urethra from the scrotum, which I always examine my patients before, once they're under anesthesia to see if I can, I'm going to do it that way because it's a lot easier for them to heal that way. And I get excellent results doing it that way as well. Um, you can get back to your normal activity, non-strenuous activity fairly early, like within a few days. I want you walking that night if possible, or the next day for sure. I don't want you to lift real heavy or sit in a bathtub or anything like that for at least a few days. Um, the thing with the artificial sphincter now, I leave it open usually for 4 to 6 weeks. And the reason we do that, for one, you want this to heal in place. More importantly, the balloon that when you go to urinate and you squeeze the button and the urine goes from the cuff into the balloon, that balloon has to heal open. So if scar tissue heals around it and closes, then that fluid is not going to be able to get into the balloon. So we let it heal for 4 to 6 weeks with the balloon up, or yes, with the balloon up and the sphincter deactivated. So everything will heal in place. The balloon will be open, so when we need it, it can hold the fluid. That's the basic reason for it. That's one of the few downsides to this procedure is you have two things. What really, one is it's you have to have some manual dexterity to use it, albeit very little, and you have to wait 4 to 6 weeks for it to start working. Where with the mill sling, it really starts working right away. Next slide. So what about patient satisfaction rate? They say 90% of patients report long-term satisfaction. I'd agree with that 100%. 90+% would get another artificial sphincter if they needed it again, and 94% would recommend it to family or friends. I can just tell you from my experience, it's one of these things where if I put one in and the patient's doing really well, I'm not going to hear from them for 10 years. When it breaks, they're outside scratching on the door trying to get another one. It's not like, yeah, maybe. It's like they're literally scratching on my door trying to get in to get another one as fast as possible. And I'm not kidding about that. I'm not making that up. Some of the studies they're showing 85% no pads or maybe one small pad. There's another study showing 96%, another one showing 90%. Basically, I mean, 9 out of 10 patients, you're going to be using hopefully 0 to 1 pad. Now, for someone who's going from, say, 9 diapers a day down to 0 to 1 pad, it's life changing for them. It's one of my favorite things to do because you can give somebody such a much better quality of life with a procedure like this. Next slide. So, long term stress urinary incontinence treatment and cost coverage. Okay. So, treatment for the advanced sling or the artificial urinary sphincter. It's covered by Medicare and most private insurances. And there's good reason for that. Besides, your quality of life is terrible when you're leaking urine like that. Um, excuse me, I'm sorry. Your quality of life is significantly better. But a lot of the reason they are very willing to pay for something like that, like whether it be Medicare or an insurance company, the majority of accidents occur like broken hips, subdural hematomas, things or entities that are very life-threatening you didn't know about. We're going to get this covered up front for you. Next slide. And my staff's been with me 25 years, so they know what they're doing as far as getting things covered and what we need to do to get something covered. So the intended benefits of stress incontinence treatments is to achieve bladder control, to get you out of pads, to get you out of diapers, to be able to urinate when you want to urinate, right? The implant isn't detectable. You can't see it on the outside of your body. The patient satisfaction rate is huge, okay? Your quality of life improvement is huge. So the idea is to help you restore normalcy and help you get your confidence back. One of the things that happens is patients will tend not to go out of the house much when they're leaking like that. Why? Because they don't want to be embarrassed. So it gets their confidence back, it gets them out there. I'm going to tell you one story real quick. There's a patient of mine, and it's a really long story, but basically, I told this gentleman not to have surgery because had a really advanced prostate cancer. He's very heavy, he's very overweight, he retains fluid. And I told him, I said, if you have surgery, you're going to need radiation afterwards as well. You're going to leak terrible. You're going to be miserable. And he was. And he's to a degree not the nicest person either. He's really nice now though. But anyways, he was using 9 pads a day after not 9 pads, 9 diapers a day after radiation. And we just a few weeks ago put an artificial urinary sphincter in. And in his case, I used 2 cuffs instead of 1 cuff just because his incontinence was so bad. He's completely dry. He is elated. He went out, he got a girlfriend. Now he wants a penile implant. I mean, that's the kind of difference we can make in people's lives with this type of procedure. Next slide. So, with any surgery, there's always risks involved. Not all patients are a good candidate for a sling or an artificial sphincter. That's true, but most people are a pretty good candidate. Okay. So, with the male sling, the risk can be device failure. And mainly when I see device failure is when somebody will have one put in because they like the idea of the sling and not having to do anything, but they have too much leakage for this, excuse me, for the sling to work. And the idea is you can take it out and put in a sphincter, artificial sphincter later. I'm kind of a one and done kind of surgeon. Like I want to do it right the first time and get you on your way. But that's usually when I see device failure is when you put in a sling when they're really leaking too much for a sling. Urinary retention is when you can't urinate at all. You'd have to make that sling so tight. I'm not even sure you can get it tight enough to get retention, but it can happen. You can get postoperative pain with a sling, and you can get irritation at the wound site. You can also get infection. Complications of the artificial sphincter, again, the device can malfunction and it may require a revision surgery. Now, usually, not always, don't quote me, but usually these last somewhere between 10 and 15 years. I'd say the majority of my patients come back, if they come back, 12 years, something like that. So it may require another surgery later on. And there's a couple reasons for that. And, before I go down the line here, let me go over those with you. The most common thing I think we see is there's a cuff that goes around the urethra, right? So that has to be sized perfectly. So it has to squeeze, not too hard, but squeeze enough where you're not leaking urine. As time goes on, the urethra tends to atrophy and get smaller. So now instead of fitting perfectly here, the urethra is smaller and it may not close properly. So that's one of the reasons we see them gradually tend to fail over 12 to 15 years because the urethra underneath the cuff gets smaller. So we might have to revise it and put a new one in a slightly different area on the urethra where the tissue is fresher or more vascularized. You can get erosion of the urethra from the cuff. Um, really try to avoid that, but can it happen? Sure. Yes, it can. If that happens, we generally have to take it out. I just had to do that on a patient that had one for 15 years. It's not all that common, to be honest with you. Urinary retention occurs usually if you make the cuff too tight to start with. If you make the cuff too tight, that's a problem. You want to try to avoid that. I try to avoid that as a surgeon. Um, you don't want to make it too tight. You don't want to make it too loose, but too tight, I think, is probably a little bit worse. The biggest problem you can get seriously is probably infection. If the artificial sphincter gets infected, it generally needs to come out and we have to put a new one in later on. You can have pain, you can have soreness. The pain and soreness, if it's not infected, generally will go away within the first 4 to 6, sooner than 4 to 6 weeks, but it'll generally go away in a few weeks. It's not usually a long-term problem. Have I seen it? Yes. Does it happen very often? No. Next slide. So, stress urinary incontinence in summary. It's a known side effect of prostate cancer treatment, but other types of cancer treatments and neurologic diseases and problems as well, right? There's a variety of treatment options. A lot of the treatments are uncomfortable or lead to a poor quality of life. An artificial sphincter or a sling offers you a long-term solution, excellent treatment outcomes, and significant improvement in your quality of life. So speak to your urologist to understand your options. Um, I'd speak to somebody who's done a lot of them. I've done a lot of them. Um, been doing them for 35 years, maybe. I like to think I'm better at it now than I used to be 30 years ago. Hope I am, but I do a lot of them. I would definitely see somebody who does a lot of them if you're going to seek treatment for this problem. Next slide. So you can scan that QR code to take a short quiz about your symptoms. Next slide. Hey, I think we're done. If you want to make an appointment with me, I'm from Southeast Valley Urology, and we're a division of Ironwood Physicians, Cancer and Research. Our phone number is listed there, 480-924-7333. My website is www.southeastvalleyurology.com.